these are the T2 weighted MR images, axial sections of the brain in a child with complaint of seizures. I can appreciate that there is a well-defined abnormal signal intensity lesion located in the right superior cerebellar peduncle, which is showing peripheral hyperintensity and central hypointensity on T2 weighted images. There is mild to moderate surrounding edematous changes appearing hyperintense in the white matter. Uh, Now I'm looking for any additional image lesions in the rest of the brain parenchyma. The supratentorial brain parenchyma appears unremarkable. No additional lesions are seen.
Yes.
There is a solitary lesion in the right superior cerebral peduncle. I would like to see it on other sequences to further characterize the lesion.
What do you want?
Sir, I want first T1.
T1? This is T1. Go on.
Sir, it is moving very slowly.
Okay.
Sir, on T1 weighted images, the lesion is showing peripheral hypointensity with central ISO 2 hyperintense areas. Sir, can I look at the GRE sequence? I'm suspecting hemorrhage in this area.
Okay.
The GRE sequence does not demonstrate any blooming artifacts.
Yes.
Sir, can I have the contrast enhanced sequence?
Yes, a contrast.
So on contrast enhanced sequence, the lesion is showing there are actually two lesions. I think there are two lesions, one smaller, one larger. The larger one is showing, both the lesions are showing ring enhancement with central non-enhancing area. Sir, can I have the diffusion weighted?
This is the diffusion.
Sir, on the diffusion weighted imaging, this lesion is not showing restriction. So, sir, this is peripherally enhancing lesion which is not showing restriction. The differential comes to which comes to my mind are either it is an uh, demyelinating plaque
What else?
and also ring enhancing lesion which is not showing restriction in a child. It can be astrocytoma, but there
What
are two
else?
lesions, and or it can be cysticercosis, but there are not multiple lesions. Only two lesions are there.
So what's your
Uh,
final diagnosis? Or
Sir,
what else?
final. I think
What
it's
else?
demyelinating plaque.
What do you think demyelinating plaque has this appearance of enhancement?
Uh, Sir, active
What is
demyelinating plaques have may show ring enhancement.
have what? Have ring? Are you sure?
Usually, sir, they have an open ring enhancement.
This is not a ring.
not
So this is
occurring in husband.
is this
Sir,
possible
for
to
in a
be?
child,
Hmm.
metastasis is less common. Uh,
Okay. What else?
uh, it can be a tuberculoma.
Okay. So what will you do next?
Sir, next, I will inform the referring clinician about the findings.
Before
And
informing the clinician that the patient is still in your department, what do you want to do
sir,
for him? Hmm.
sir, mm, there are no other lesions in the rest of the brain parenchyma. This is a solitary lesion. Uh,
If I told you what do you want to ask about? Any history, any
Sir, any
examinations?
we can ask for a patient's chest X-ray or patient any family history or previous imaging. Uh, uh,
What do you think?
this is the CT scan, axial slices chest, HRCT scan, axial slices of chest lung window.
Yes, yes. What's your diagnosis?
So there is airspace consolidation with nodularity in the right upper lobe.
Okay. So what's your
So it
diagnosis
is
here?
most likely, sir, tuberculoma.
What will you do next?
So patient needs to be isolated and contact screening should be done and infectious control authorities should be informed about this lesion, this patient, and patient needs to be isolated and treated medically.
Thank you. Could you know uh, why you didn't pick up that this is the tuberculoma? Which sequence you didn't ask or look for or look in it at all? The only
Flare,
sequence, no. The only sequence that you didn't ask, it was the key sequence for tuberculoma. Which one? What is the differential point between tuberculoma and the others in brain?
sir,
Look here.
mm,
What is
T2, T2,
T2? Excellent. What have it in the center?
center hypointensity with peripheral
Yes.
hypertension.
Yes, this is
Sir,
very characteristic of
characteristic of tuberculoma.
of peripherally enhancing lesion, and the wall is uniform, looks like an abscess, but without
Abscess
high T2. See,
without
this
high
is the
T2.
point. Without high T2.
Sir,
Why? Yeah, why tuberculoma has low T2? Why? Yeah. Why
uh,
tuberculoma has also the center is non-restricted. Why? There are a
Sir,
pathological cause.
proteinaceous
No,
elements are
no,
there in the abscess
no, no, no.
or
This is not, doctor, one second.
lactate.
One second. Doctor, one second. This is not an abscess. This is this is not an abscess. This is a tuberculoma.
Tuberculoma shows caseation necrosis,
Hmm.
and sir, there is, I think, lactate
Yes,
is there.
see, because the center contain back cell or back granuloma cell. The
Granulomatous
granuloma
cells.
cell because it's cells, so it will be low T2. Okay, so the enhancement here, okay, will involve the center. How to differentiate between tuberous abscess and tuberculoma, the T2. Okay, this is the most important point. Thank you, Dr.
Okay, doctor.
Such. Thank you, my colleague. By the way, it is very difficult case. And I told you before, I'm trying to bring what is out of the box, what in which case is typical, and present to you. This is a 10-year-old patient, and the history is misleading. And you find these two lesion in the right mid-cellular lung. It first come in mind, this is tumor. really يعني very logical like this. But we should, this case shows the importance of conventional sequences like T1 and T2. If we have a look at T2, immediately we can at least tell the tuberculoma from the beginning. Okay, my colleague, so that reveal the importance of conventional sequences. Very important to look, especially in brain. In T2, to rule out tuberculoma, and in T1, generally to rule out any hemorrhage. Very important. If the examiner guide you, no, show this, please. Look at this slide. He is helping you too much. But if the examiner left you generally with the sequence, take it one by one. T1, T2, flare. In my opinion, T1 is very critical than flare because you can detect hemorrhage. T2 is very critical in this ring enhancing to rule out tuberculosis. Why? Because see, very big difference between astrocytoma or whatever tumor and the tuberculoma. Two different pathways. If we give a diagnosis like this, the patient will go to cancer institute. But finally, with a good diagnosis, it is a tuberculoma. Thank you so much. Next candidate.
Hello, sir.
Doctor, this is 5-year-old female patient complaining of um, developmental motor abnormalities. Can you request control, please?
Um,
Or
not
shall I
able.
scroll for you? Okay, yeah, go on. Go on, doctor.
Okay, I've been provided with axial T2-weighted image of a young patient. I can see that there is abnormal signal intensity in the extraaxial spaces where there is high signal intensity appearing cystic. And this is also extending along the posterior parieto-occipital and temporal regions. Um, would also trying to look for if there's any communication with the ventricles. Not entirely certain on this image. I would like to, okay, I can see that there is some communication with the ventricles. Also, I cannot see the septum pellucidum clearly.
Yes.
Also like to look at the coronal images of this patient, and I would like to look for any associated uh, anomalies with migrational disorders. I don't see any abnormalities around the ventricles to suggest any migrational abnormalities. Other than this, I would also like to look at the optic nerves as well, to look for any associated abnormalities of the optic nerves. Okay, I can see that the optic nerves appear to be hypoplastic. They appear to be smaller than normal. So given the features of and also I wanted to look for the optic chiasma on coronal. I wasn't able to clearly see it on the axial images. Okay, the optic chiasma also appears to be slightly reduced volume than normal. So given the absence of the septum pellucidum and the hypoplastic optic nerves and optic chiasm, my primary differential is a septo-optic dysplasia in this patient. I would inform my findings to the referring physician and also
What else? Okay, what else?
um, okay, I can also see the abnormal communication with the lateral ventricles. So this is in a patient with schizoencephaly due to I can see that the gray matter is clearly lined adjacent to the connection. So this is likely to be a schizoencephaly. I don't see any abnormal gray matter signal intensities around the schizencephaly. Um, so I would inform my findings to the referring physician, and this is likely the cause of the patient's uh, clinical condition. Um, Not able
Thank you,
to.
doctor. Thank you, doctor, so much. Really brilliant. It is a case of septo-optic dysplasia. What happened here, my colleagues, there are absence of cavum septum pellucidum. Then the doctor asked to have a look at both optic nerves, which is markedly atrophic. And then he asked to, and this is his right, by the way, to have a look at the optic chiasma atrophy. So it is a very classic septo-optic dysplasia. Plus, there are a defect here. Okay, there are schizencephaly here, open cleft, and there are another one here. Okay, two schizencephaly. Thank you, doctor, so much. Plus, there are abnormal white matter. This white matter, at least frontal, is not normal, but the patient has too big disaster. Thank you, doctor, so much.
Thank you, doctor.
Take care, my colleagues, of the absence of septum pellucidum. Very important. You must it increase the suspicion of septo-optic dysplasia. It is one of the midline anomaly, cleavage anomaly, which يعني septo-optic dysplasia it can be a يعني part or related to the holobrachencephaly because all of them has septum pellucidum absence. Thank you, doctor, so much. Next candidate.
Assalamu alaikum.
Salam. Doctor, this is 25-year-old female patient complaining of gradual right eye loss and bilateral lower limb paresthesia. Can you request control?
Yes, I requested.
Okay, go on.
I'm provided with this T2 axial slices of a 25-year-old female patient. I'm unable to scroll.
I will scroll for you. Leave the mouse.
So here I can see bilateral signal abnormalities, which are high T2.
Yes.
The largest one is in the right side frontal region, and all of these lesions appears to be intraaxial. However, I can't see the screen, the images.
Yes, yeah. Yes.
Yes, now I can see. So I can see T2's hyperintense signals in bilaterally, larger one on the right side in the frontal lobe, and there is a occipital horn at the right lateral ventricle.
Yes.
There is to be some mass effect and surrounding low signal intensity, and there is a mild mass effect over the ventricular system. Because these lesions are multiple and bilateral, and the patient is young, so I'm also looking at the dural sinuses, which are normal flow void. Practice, I will check the other sequences. There is no posterior fossa abnormality, so I'll check the.
This is other sequences.
Yeah, the player also shows high signals bilaterally, and these is to be predominantly a white matter based, reaching subcortically, but there is no.
Which sequence? Okay. Which sequence do you want else?
A DWI to look for the restriction, and then so there are only the margins are slightly restricting, but there is no central restriction. And I would like to check the post-contrast images for any enhancement.
This is a post-contrast.
Yeah, so these lesions shows open ring enhancement.
What's your diagnosis?
So this is like the active demyelinating plaques of multiple.
Okay. What is the specific name of this type of demyelinating?
Yes, liquid. I forgot the name. It's like eating up the brain parenchyma.
No. What else?
Tumefactive.
Yes. What is the meaning of tumefactive?
Like it's eating or liquefying the brain matter, and it's rapidly progressing.
No, tumefactive is not eating the brain matter. It is due to another case.
Okay.
And another cause. When you name this plex a tumefactive, according to which criteria?
Sorry, sir, I can't remember this point.
Okay. See, doctor, according to size,
Oh,
according to the size. Look
mhm,
here,
mhm.
Tumefactive when it is more than 2 cm. I'm searching here where aggressive. Anyway, see, here. Tumefactive when, look, greater than 2 cm here.
Chemical, okay.
Can mimic neoplasm. This is
Mhm.
why it is named tumefactive. Tumefactive came from tumor,
Oh,
looks like tumor, because when you look at this lesion, you may consider them, what is this? It is a tumor like. This
mhm.
is the main cause of naming it a tumefactive. Tumefactive means tumor size, tumor like, something like this. Thank you, doctor. You did very well. The open ring is very characteristic to demyelination.
Yes.
Plus, this one is at the splenium of the corpus callosum, and even this, at the geno, this one may touch the splenium. Okay, so take
Yeah.
care, my colleague. This is open ring, but the sizes is large. May confuse us with tumors, but the open ring will push you to give safely a diagnosis of tumefactive MS. Thank you, doctor, so much. Next candidate.
Hello, sir. Good evening.
Hello. This is
Hello, good evening, sir.
post-traumatic.
Yes.
Good evening. Post-traumatic patient have right shoulder weakness.
Okay. Sir, I've requested
Go on.
control.
Yeah, go on.
Okay. Sir, it's not scrolling. Will you please hold for
1
me?
second. 1 second. 1 second. 1 second. You can use the arrow. Okay, let me scroll for you. Let me.
Okay, so I'm presented with MRI scan of shoulder of a patient with trauma. These are the coronal T2 sections, T2-weighted, yes, T2-weighted images. I can see that there is large T2 hypointense infiltrating areas in the subcutaneous and intramuscular plane of right shoulder.
Mm-hmm.
Bilateral thyroids are enlarged with multiple follicles. I would like to check the other sequence T1 axial, please. Till steer, okay.
Yes, T1.
Okay, I can appreciate there is large multiloculated T1 and T2 hyperintense lesion, which is insinuating in the fat planes and intramuscular planes in right shoulder. So in my routine practice, I would like to check with the history and the
Trauma. Trauma. Hello? Hello?
so do you have, yes, so do you have axial steer images?
Axial steer. This is axial steer.
Okay. So yes, I can appreciate that in axial steer also the lesions are not suppressed. It is hyperintense in axial steer. So in my routine practice, I would ask for the history compared with the previous images. It may be the appearances are keeping with uh, some soft tissue sarcoma or any insinuating lesion like.
What will you do next?
Sir, it can be lymphangioma.
What?
I would
Okay, what will you do next?
discuss the findings with the referring clinician and ask and send the patient for sarcoma center for further
Okay.
evaluation and
Okay.
tissue diagnosis.
Okay. Doctor, could you have a look here again? This is T1. What is
Yes.
this? Where is the muscle? Where is the muscle in this site? And the history is trauma. Where is the muscle? Here.
Okay.
Where is the muscle here? Look.
It is replaced by the
Yes. By what?
by fatty tissue.
Okay. So post-traumatic fatty
No.
changes of the muscle. What does it mean
Okay.
for you? What does it mean for you?
I would like to compare with the other side. Can it be Duchenne? Like
No, it is not possible. What does it mean? Market, see, look here. Market fatty infiltration of this region, which is a region of multiple muscles. See? See?
fatty atrophy, fatty replacement of the muscle
Okay.
after atrophy.
Okay. What come in your mind post-traumatic cause of fatty atrophy? Look here. There are no muscle here. Only
I think
there are.
muscle atrophy with the fatty replacement.
Why? Why does it happen after trauma? What is it in trigger in your mind? Something injured. Look here. Look at this slice. What happened? Look here.
The, yes, there is replacement of the tissue by fat.
Yes. We finish this point. Look here. What is this? Follow this one. Follow. What is this?
This is okay. There is post-traumatic. Okay,
Yes.
post-traumatic denervation. It can be muscle injury, nerve and muscle injury. Nerve injury it can be, and so it can. It is replaced by fatty change.
Post-traumatic what? Post-traumatic what?
Nerve injury.
Okay. Which nerve injury?
Nerves of brachial plexus, which supplies the muscle.
Okay. Could you show me which nerve? I'm scrolling for you. Stop me.
Yes, I said the thin one. This one.
Hmm? Hmm.
This thin.
Okay.
So this one, it will be suprascapular. Sir, I don't remember exactly.
Okay. So what's your diagnosis?
It is post-traumatic denervation injury and
Fatty
with fatty
atrophy.
replacement of the muscle, fatty atrophy of the muscle
Okay.
after
Thank you, doctor.
post-traumatic fatty atrophy of the muscle.
Okay. Thank you, doctor, so much. It is also a difficult case. See, my colleague, the examiner gave you one case, and he told you this is a trauma, and you see the shoulder, leave the mouse please, and the triangular here, posterior triangle, is totally bright in T1. What come in your mind? This is a fatty infiltration. One word in your mind. So you must search for an injury for the brachial plexus. How to get the brachial plexus? By the way, this is the brachial plexus, and if you see, it is looks like retracted here.
Okay.
But for all of us, follow the artery, subclavian artery, this one. At least in the axial, very easy to pick up it because it is between scalenus anterior and the scalenus medius. Maybe in sagittal eyes. Look here, my colleague. This is the artery, subclavian artery. Okay. Look here. You should see a lot of nerves here, whatever this is cord, this is divisions. We are not expert by this brachial plexus. Second point, you can bring the coronal and look at the neural exit. Look here. This one filled with fluid and nearly you can't see any nerve here. How can be you sure? Compare with any other foramen. I will show one. Look this one. This is a nerve. This is intact. Okay. This
Okay.
one intact, but compare the lower one. It is difficult, by the way. Look here. Completely failed, and see the nerve is retracted here. This
Okay.
tortuous nerve because it is retracted from here. In the axial also, look here. See, you can compare with left. Right with left. We need to magnify more. At least I wanted to show one. Obvious. At least you can pick up pseudo-meningioma like this. We need more magnification, by the way. If you look here, this is more fluid and it looks like cyst or sac-like than here because this is the nerve.
Yeah.
This is the intake. But
Okay.
here, only fluid. This is a pseudo-meningioma. Okay? You will go one by
Okay.
one, but at least if you give the examiner the good diagnosis, you are not requested to give a full details in 5 minutes about very complicated case like this. This is the artery, and all of these are the cords, or whatever, the parts of brachial plexus. The parts should be like straight lines, not aggregated like this, not retracted. So what will we do? We will pick up the sagittal stair especially and follow the artery. See? From the nerve
Okay.
roads or nerve roads or neural exit, you should not see these fluids. Okay? And you should see some nerves come straight, not like this aggregated and retracted. So it was a chronic brachial plexus injury with atrophy, fatty atrophy. If it is
Okay.
acute, it will show edema and called denervation, edema or denervation myopathy. Thank you, doctor, so much. The most important of our sessions to cover any atypical case. You will be happy when you answer it, all of you, inside the exam, not with me. So don't worry. It is very acceptable now because, as I told you many times, I bring very difficult case. Next candidate.
Sir, one question. Will the
Yes,
shoulder
sir.
cases be given MRI in
What?
exam? The shoulder cases, shoulder MRI, are they like probable in the exam? There will
Which
be
shoulder?
significant.
This is brachial plexus.
Okay. Okay.
And the
Thank
shoulder,
you.
see my colleagues, the exam يعني is number one, depend on your effort. Number two, God support, and some of luck. As I get feedback from some candidate of John, especially, many of them talk about the atypical cases. So I'm trying to cover as much as possible. So let's do our best and let's wait the result. Whatever what will happen, this is out of our hand. Next candidate, 60-year-old male patient with altered mental state.
Yes,
He has Glasgow scale 3. Doctor, do you know the Glasgow?
yes, sir. It takes
What
into
is
account three components.
no,
Yeah,
no, no,
this is about
no, no. The number, the normal number or level. What is the normal
E4,
number?
V5, M6.
But they give a degree from 15, I think.
Yeah, total is 15, sir.
Yeah, okay. Okay. You look like have an MD in internal medicine. Go on. This
Yeah, I'll
patient
just
has,
take a minute to scroll through the images, sir.
yeah, go on. The patient has
I'll just take
altered
a minute to
consciousness.
scroll.
Yeah, go
Yeah.
on.
I'm not able to scroll, sir. Can you please scroll for me?
Okay.
Yeah. So I'm provided with a axial plain CT of a patient, 60-year-old patient who had a low Glasgow coma scale. Both the cerebral hemispheres are appearing unremarkable. There is no evidence of any midline shift. I'm not seeing any obvious large territorial infarcts. There is no hydrocephalus. The posterior fossa also appears unremarkable. I feel there is some ill-defined subtle hypodensity in the region of the temporal lobes bilaterally.
Temporal?
And also
No. Don't
in
don't mind about it. What else?
the brainstem also, in the region of the midbrain and the pons. Yeah, there is hypodensity in the region of the brainstem. I would want to confirm this on the sagittal imaging. Yeah, so there is hypodensity involving the region of the midbrain and the pons. So if this patient has an MRI, I would want to look at the MRI images.
Could you have another look, please? Old patient and has very deep coma. Okay. What is
He's having
your review areas? You didn't tell me about many so important things.
I think the basilar artery is appearing hyperdenser.
Okay. So
So I'm thinking of a basilar artery thrombosis, which is causing an infarct in the posterior circulation.
what will you do next?
So I would want to confirm this with a CT angiogram or an MRI angiogram.
Okay. I think this is MRI.
So I'm
Okay.
provided with axial diffusion.
Okay, this is
Yeah.
MRI follow up. What
So the
happened?
CT image is showing the contrast enhanced CT image is seen, sir.
This is a non-contrast now.
Okay. So I'm able to again see that there is hyperdensity within the basilar artery, and there is hypodensity involving the region of the brainstem. So my diagnosis here would be a basilar artery thrombosis causing a posterior circulation acute infarction. So I would want to confirm this with a MRI or with a contrast enhanced CT images. On the MRI, I'm able to see that there are multiple areas of diffusion hyperintensity involving the posterior fossa as well as the left temporal lobe and also in the region of the thalamus on the
What
right
is your
side
next
as
step?
well.
What
So
is your
I would
next
want to
step?
see this on ADC to confirm if there is drop. And these look
Okay.
like these are restricted diffusion. So I would want to look at the MR angiogram to confirm the diagnosis of a basilar artery thrombosis.
What else?
I would
What
want to
else?
look at the T2 imaging, sir, to see for loss of flow void.
What else? What else? What is your next step?
Do we have an ADC, sir?
Doctor, you confirm this is an acute brain insult. What is your next
Yes.
step?
I would urgently inform the referring physician that there are multiple acute infarcts and there is a suspicion of a basilar artery thrombosis. And the
Suspicion
patient
or
will
confirm it?
need.
No. 1 second. Suspicion or it is sure? You
No,
are
it is sure
sure?
that it is a basilar artery thrombosis causing multiple infarcts.
Thank
So
you,
this
doctor,
patient
so
will need
much. Yes, urgent what?
urgent neurosurgical referral.
Okay, thank you, doctor, so much. My colleague, very important, very classic. An old patient with deep coma and The CT looks like normal. No any infarction, hemorrhage. Your next step before any other review area, check the basilar artery. Nothing else. Okay? Nothing. Why? Because basilar artery thrombosis causes severe coma due to the brainstem infarction without any supratentorial abnormality. It is acceptable. Okay? So one key in your exam. Second point, even if you didn't know this base or this role, check your review areas. In old age with coma, you must tell the examiner about either there are any hyperdense sign here or here, MCA, dense sign, Macca sign, whatever, and the basilar artery. Like this, you smashed the case from minute one. Whatever comes after that, it is a normal consequences. But if you didn't pick up this from the plain city, it will not be يعني good for you. Sure, here the CT angio here is showing tip of the basilar occlusion. Nothing. But the most important, the non-contrast. Okay, my colleague. Thank you so
Yes,
much. Next candidate.
thank you, sir.
Okay.
Yes, Dr. Rami, how are you?
Welcome. How are you? 40-year-old female patient with severe headache, fever, and blurred vision. Go on.
Okay, this is MRI axial T2 for a patient presented with blurred vision. Okay, first thing I have noticed that there is bilateral increase perioptic CSF spaces, and I will go further to check the rest of the images. I can't see any abnormal area in the brain parenchyma, cerebellum, occipital lobes, and the rest of the supratentorial brain. There is also no extraaxial collection. I would like to check the vessels.
Do
So
you
I
remember? Do you
can
remember
see
the history?
patient presented with blurred vision, right?
And
No, I can't remember. And what? Sorry.
the history here is very important in this case. I will not give you the history again. Go on.
Okay.
Sure. Mhm.
I can't see any abnormal fluvoid
Okay.
vessels.
Which sequence do you want?
I would like to check the T1 and diffusion. Okay, can I?
Mouse?
Yeah.
Okay. Choose what do you want from the list.
Okay, I will check the diffusion to see if there's any diffusion restriction. I can't appreciate diffusion restriction in the diffusion. So I would like to check if can I check the flare sequence?
Yes.
Okay, this is a flare sequence. I will go check it.
Can I help you?
Yes, please.
This patient has fever.
Fever, okay. As the patient has a fever, so I'm thinking I think there is abnormal signal noted in the temporal lobes.
Okay.
And doesn't show any diffusion restriction.
Okay. What
So
else?
what else? Check thing. Just a moment, checking. I think there's also high signal noted in bilateral thalamus
Okay.
and caudate.
Okay.
So can I check the contrast?
Leave the mouse. Leave the mouse. This is the thing.
Okay, in the contrast study, I can see that I can see abnormal enhancement in the brain parenchyma. There's some leptomeningeal enhancement.
Okay.
Noted. The vessels appear normal.
So what's your diagnosis?
For leptomeningeal enhancement, I'm thinking this might be meningitis. So I would like to check if there is any cause for the meningitis. I would like to check the mastoids and the sinuses.
What is the best sequence to confirm meningitis?
The flare.
Only sequence made for meningitis. Very dedicated. I have never seen this sequence done for any other disease in the brain. Anyone know? Because it is very rare sequence. All of us know it, but we can't expect this type of sequence is done for meningitis. Anyone know?
Flare, the flare sequence.
Dr. Throsy, excellent. Thank you. Okay, someone answer it. I will answer later on. So, what's your final diagnosis, doctor?
Case of meningitis.
Okay, what will you do next?
I will combine, this is an emergency. I will combine my finding to the referring physician and call them that patient need urgent neurology review and need to take medication, and also they might need to relate with the CSF fluid lumbar puncture.
What else?
What else? Sorry, in the management?
Yes.
Yes, they can. I will advise them to do lumbar puncture correlation because the patient has no hydrocephalus, so there is no contraindication of the lumbar puncture. And I would like to check if I can see in the T2 the mastoid and sinusitis. I don't think there was. Yeah, there is no mastoid fusion.
Okay,
And
thank
I
you,
can't see
doctor, so much.
sinusitis.
It was
Thank you.
very difficult case. Isolation of the patient. Meningitis is
meningitis, yes. Isolation, sorry,
infective, consumable. Okay,
yeah.
very important. Thank you so
Yes.
much. What happened here, my colleague? Look at the flare. The most important sequence of the meningitis is flare, and not only flare with contrast. You will not leave the mouse, doctor, please. You will not see in any other diseases this post-contrast flare. Okay, only in meningitis. Very important. Okay, so if the examiner give you flare with contrast, be worried about meningitis. What happened here, my colleague? Look here, from the beginning, there are in T2 at least abnormal bright signal in the basal ganglia, but at least very obvious here in both medial or mesial temporal and the hippocampus. At least you should tell about this. Second, don't forget, doctor, please, the history. Why you start with the orbit? Hello?
Hello,
Hello?
sir. Image is not. Hello.
You don't know what happened? Okay. Today is the day of software challenge. Really. And second, my colleague. It is another challenge than the internet. Microsoft update. Okay. Anyway, what happened here? At least you pick up this abnormality here in mesial temporal and hippocampus, and we are worried about this basal ganglia. So take the flare. At least here there are abnormality here. But look here. What is this? Doctor, last candidate, what is this? What happened here?
There is a effacement of the sulci.
There are no sulci. The sulci
Yeah.
filled with high density or bright signal fluid. Why? Look here. The sulci should be like the CSF here, and they should like this sulci. This is the normal sulci. Okay, this is the normal, maybe normal sulci.
Yeah.
Okay, but here the sulci, the CSF in sulci failed to be suppressed. Why? Because there are a proteinaceous material, whatever, there are abnormality here. Okay, this is the way. Then the patient has fever. Then look here. Look here. There are leptomeningeal enhancement, and there are curvilinear enhancement smearing the sulci. This is a subarachnoid enhancement also. Look here. You should not see this type of enhancement at all. Look. What is this? What is this?
Yeah. Yes.
So this is meningitis. This is meningitis. The meninges is slightly thickened. And look here also, there are a little bit signal here. Okay? Little bit maybe enhancement, maybe from the flare itself without contrast. The patient has fever and the cerebral abnormal signal and the meningeal enhancement. So it was a case of encephalomeningitis. Why I bring this case to see here the flare. To check the flare very well in all patients with fever and the brain symptoms. Search for meningitis. Can this case be presented in the exam? In my opinion, sure. Why? It is emergency and basic case. Why we as a radiologist confusing with this case? Because we are not familiar with this type of cases. Apart from colleagues that working in endemic hospitals or infection hospitals like this, they are very familiar, sure. Or neurology hospitals. Thank you, doctor, so much. Also,
Doctor, can I ask a question regarding another previous case?
Yes.
The case of brachial plexus. We said fatty infiltration in the muscle. If it's fat, why it doesn't drop the signal in the stir? Because in the stir images, the signal is still high.
See, in the stir, there are two entities in the last case. Number one, the injury of the brachial plexus itself and the replacing of the nerve tract by either meningocele or fluid. Okay, this is the main pathology.
Yeah, I thought it's edema. I thought it's edema in the muscle because it's or if it's even blood because it's high in T1 and it's not suppressed in the stir.
1 second, yeah. 1 second.
Okay, doctor.
I will bring the case for you. This is the history. I think. Close it. 1, 2, 3. Okay, maybe this one. I see. What happened here? What is the sequence here? This is T1. Are you agree with me? There are fatty infiltration? Here?
Yeah, yes, okay.
Where?
This is
Where's
high
this fatty infiltration? In the muscle.
in the muscles, yeah.
But look here at around the brachial plexus. Look here around the nerve roots. I will put side by side. Very intelligent question. See, this is the stair. This is the T1. Okay? This is fat. Look here. Where is the stair?
I think both of them are stairs, doctor. So this is a stair and the other one is a stair. Because
This is T1. Okay.
yeah, this now is T1.
This is fat. Okay? What happened here? I think this is not stairs. Because if it is, this is stairs. What happened? Look around the brachial plexus, you will see this fluid. Okay? This is the brachial plexus. Okay? You will see fluid. There are one, I think this one more very, I see. This is very good stair. Look here, this is fluid. Are you agree with me?
Yes.
Okay? This is fluid, so it is very bright, but in a stair. Very bright.
Yeah, so
you
so
agree?
this is a yeah, because it's a bright in the stair, so it's not fat.
Where is it? Around the injury site of the brachial plexus. But the fat is within the muscle. Look, the brachial plexus is this one. This one,
Okay.
this pathway, but the fat here in the muscle. Is it clear
Okay.
for you?
Yeah, yeah, yeah.
Is
Thank
it
you,
clear?
doctor. Yes,
Okay.
yes, okay. Okay,
Thank
thank you, doctor.
you.
Thank you.
Next candidate.
Hello, Assalamu alaikum, sir.
Assalam. Doctor, this is a young child who has underdevelopment. See, 10-week male with developmental abnormalities. Go on.
Okay, these are T2 weighted axial MRI images of the brain of 10 weeks old child having developmental abnormalities. I can appreciate that there is a CSF density area involving the right frontal region. It is somewhat causing a mass effect on the underlying RI. The and also ipsilateral frontal horn of the ipsilateral lateral ventricle. I can see that there are also nodules along the periventricular region. So can you please scroll? Yeah, heterotopic gray matter is also noted in the periventricular region. Besides this, also somewhat abnormal gyri were also seen as, in the vicinity of this high intensity region. Also, there is also, there are also other lesions in the, this is 10-week old. So in the, in the frontal region, there is also tonsillar herniation is also seen, and crowding of the posterior fossa was also noted. And along the, there is also somewhat protrusion of the brain CSF and also the brain parenchyma, the frontal horn, through a defect in the frontal region, extending and reaching up to the subcutaneous tissues preseptal space. In my routine practice, I would also like to see the whole of the neural axis. But in summary, in this case, with the protrusion of the brain parenchyma through a defect in the frontal region and also CSF intensity region, and
What is the name of
besides
this? What is the name of this finding?
encapsulocele, frontal encapsulocele.
Okay.
Okay.
And also, yeah, frontal encephalocele, but I was also suspecting some heterotopic gray matter. This is not obvious in this case, in this FLAIR images, in this, but I was suspecting on the T2 weighted images. So I will inform the findings to the referring physician, and also will suggest referral to the pediatric neuro surgical referral, and also will reassure the
Thank you,
parents.
doctor. Really, thank
regarding
you so
this.
much. Really, it was a case of search, satisfaction of search, but you get all the findings. Thank you. See here, my colleague.
Thank
The first thing will obscure your search. This large arachnoid right frontal cyst. Okay. And you will you should almost you may miss some of the finding, but our doctor really was brilliant. See here, there are subependymal nodules here, almost heterotopia. Somebody may told us, doctor, it may be tuberous sclerosis. Okay, search for calcification in SWI or ingredient or whatever CT, but we have here a big disaster here, herniation of the brain frontally, so frontal meningoencephalocele, and here she didn't forget to talk about this herniation. Okay, and I think if you
Yes,
notice
sir.
there are maybe some dilatation here in the central gland, maybe. So
Yes.
we can ask for whole vertebral column CT to MRI to pick up any other anomalies. Thank you really so much, doctor. Another finding, but
Thank
this time you missed it, but it is a minor finding. This sinus. This is what is the name of this?
Sir, sorry, I couldn't see your
This sinus. This one,
this.
Felix sinus
So
or
this
falcine. Yeah,
Alpha.
falcine sign. No. Minor, but
Okay.
just it was a case of search of satisfaction of search. Thank you, doctor, so much. Next
Thank you, sir.
candidate. Welcome. Next
Hello,
candidate,
doctor.
5-year-old male patient complaining of chronic headache with recent onset of mild confusion.
Okay, can I request control or you scroll
Yeah.
from?
I'm helping you. Go on.
Okay, just in case. Okay, so this is the axial. Okay, so this is axial axial CT of the head of a patient presented with chronic headache. I'll take a moment to scroll through the images.
I'm scrolling, not you.
Okay. Oh yeah. So there is a right frontal parafalcine hyperdense focal lesion seen with perifocal edema in bilateral frontal lobes. I think I can see there is CSF cleft. So this is suggesting that this is an extraaxial lesion. There is no calcifications within the lesion.
What's your diagnosis?
This is most probably parafalcine meningioma. I would like to confirm this with
what will you do next?
contrast images, post-contrast images or MRI.
We did this one. Look here,
okay.
what happened?
Okay, so in the MRI, the lesion is again demonstrated. I would like to confirm the CSF. I would like to check this in the coronal T2, if possible.
Look here. What's your diagnosis?
So this is okay. It's a homogeneous, shows homogeneous post-contrast enhancement. And there is no hydrocephalus, no. Ideally, I check for any intracranial herniation. So this is most probably, if I can see the coronal or sagittal, just to confirm the dural tail. Um, okay, I think I can see there is dural tail. Yes, so this confirms the findings.
So what's your diagnosis?
Ideally, this is parapulsine hemangioma.
Okay.
Uh,
Parapulsine what? Parapulsine meningioma. So,
Yeah. I would like to check the whole brain and to check for any other lesions, other meningiomas
okay.
or schwannomas
What do you want?
without any
Okay, okay.
symptomatic.
What do you want?
Uh, I'm, I'm checking for the rest of the images. If axial images would be better, post contrast.
Oh, this is axial post contrast. Yeah.
Okay, so I cannot see any.
So,
other
what's your
enhanced
final
lesion.
diagnosis?
So this is a case of meningioma. I would like to confirm compare with the previous images for interval
Could you remember the
change in
history?
size.
Doctor, could you remember the history?
It's chronic headache.
And
sorry, I forgot it.
I think today out of 8, four candidate forget the history in the cases which is very critical. Yani the previous case, the history is not important. Baby or whatever have a developmental anomaly. In the case of meningitis, the history was very critical. And this case, and at least one case, 3 out of 8 forget and remain with the case. You have two choices, either to remember the history or to choose another sequence. Do you think the examiners will be kind like this?
Yeah, this is what I'm.
He will give you a very easy case, very obvious meningioma.
Okay. Okay, I would like to. I would like to go through my review areas.
Okay. The patient has recent onset of mild confusion and right-sided weakness.
Right-sided weakness. Okay, I would like to check the diffusion images. Okay, there is high signal in diffusion, and if it's showing low signal in ADC, so okay, there is diffusion restriction within the.
What's your diagnosis?
Yeah, so this most probably associated hemorrhage.
Sure. Are you sure?
Then the lesion.
Doctor, the lesion is this one. We are above the lesion.
Okay, so there is yes, ACA territory acute infarct.
Yes, this is the point of this case. Take care, the examiner must assess you, so he must trick you. This is his business. This is his duty. Please, my colleague, thank you, doctor, so much. My colleague, please, don't the history, don't forget at all. Very important. Listen to him well, and at least in the beginning, keep in your mind, is this critical or none? For example, today we have 3 cases now. Okay, developmental anomaly. The case is not a big issue, but this case has emergency. Really, this is emergency brain case, and the patient have recent onset of something. The meningitis case has fever. I give you a brain MRI and you forget the patient has fever. Sure, you will lose the case. For your knowledge, all of you, especially the case of meningitis, because it was the most difficult case of today. When I prepare it, fortunately, I pick up the fever. First thing, when I saw there are no abscesses, I am trying to pick up any signs of meningitis. Nothing else. I didn't search in this case about anything else. Again, the examiner give you a case, a brain case. you should ask yourself what is about the history. And I think it is not acceptable to ask in the brain or to tell the examiner in the brain, I will compare with the previous image. Okay. But first give him a proper logic diagnosis. Okay, my colleague? The
So
examiner
doctor,
give
if we
you,
forget,
he will
sorry,
kill you.
if we forget the
He will kill,
history,
he will really,
we can
he will
ask
kill
about the
you.
history again because I have this problem.
No, no. Try, even you can write. يعني if this is a
They
big
don't. They
problem
said
for
they
you,
don't have pen. Yeah, we will not get any pen now and paper.
almost all the histories, not more than 5 words, really.
Okay.
But keep
Okay.
in your mind, this patient has fever, and he give you a brain MRI. Search for infection. This patient have, I give you MRI, and have sudden onset of something urgent. Search for sudden onset, either bleeding or infarction. That is all. Okay? What happened? You will find this one, and immediately, if you didn't forget, you will look at this. Doctor, there are restrictions. Doctor, at least I'm worried about infarction. I'm not, at least. Doctor, I think it is inseparable from the lesion, but this is the lesion, by the way. Okay? This is the lesion. Uh, so don't forget the history at all, especially in brain, especially in abdomen. But the brain is more critical. Why? The abdomen, you may get the finding, but in the brain, really many sequences. Each disease you must look in specific sequences, like the case of meningitis. I didn't, in my career, I didn't see the flare post contrast done other than the meningitis. If anyone know any other uses for this, please inform us to increase our knowledge. Somebody asked candidate 2 can start the case with saying the given history so that we don't forget. Yes, thank you. Thank you. One advice from one candidate, you can tell the exam I'm presented with contrast and non-contrast MRI of 65-year-old male patient who complaining of sudden onset of mind confusion and right-sided weakness. Like this, you remember yourself and you give a point or a hint to examiner that you listen him well. From the beginning, if you didn't listen well or if you forget, but from the beginning, tell the exam, please, what is the history? I didn't listen you well. Like this, okay? Or I didn't hear you well. This is acceptable. Okay? Thank you, my colleagues. Again, it was a case of meningioma. Okay, but this is not, the patient will not die from meningioma. Okay, the most important, the fruits are this one, the infarction. Why this happened? Because this meningioma is midline parafal sign and it compresses the left-sided ACA. See, it is inclined more to the left, and here, this is the site. I can't catch it really. This is a site of ACA. It may be compressed, it may increase in size, whatever happened. But this infarction almost due to the large size of meningioma, which compressing the left ACA. Thank you so much, my colleagues. Thank you, really, Dr. Nagam. Study well. My colleagues, after the 1 October, we will accept as regarding the policy of Dr. Naha, we will accept candidate who have seats in January. Okay, so excuse us for all of you. Thanks sure for all your attendance, but I think just the remaining 2 sessions for October candidate, hopefully they can pass. We must help them till the end. Thank you for all. Thank you, Dr. Nagam.
Sir, I have a question regarding this last case.
Yes.
Can we give the differential of lymphoma because it's showing diffusion restriction? Is it possible?
Lymphoma? Could you think is lymphoma more common? to be dural based, midline, parafal sign, or rare? See the dural tail. What do you think, doctor?
Yes, there's more favor of meningioma.
Yes, common is common. Yeah.
Doctor,
Any
Doctor, I
question?
have one. Yeah. I sometimes I don't know what's the difference between the olfactory groove and peripheral sign if it's in this place. in this
At least
location.
tell the examiner this is based on the most medial part of anterior cranial fossa. I tell you one advice for all of you. The examiner want, number one, a good logic diagnosis or even two differential. Number two, he want from you, is this urgent case? Is this tumor case? Which pathway will you push the patient? This is the most important. Why? Because some candidate today is describing too much details. For example, the case, sorry for our colleague, I'm just for the benefit of all, the tumefactive MS. Our colleague describing each one of the parietal, another one in the temporal, another. No, this is okay. You are, by the way, very accurate, but this is not the concept of FR. He want from you to tell him the concept of this case, the meaning of this case, and subsequently the true management. For example, in this case, if you told the examiner this is midline, okay, extra-axial lesion based on the anterior temporal fossa, and sorry, anterior frontal fossa, or anterior floor, the floor of anterior frontal fossa, inclined more to the left, he will be very happy. What happened? This is not a big deal. Either this parafal sign or either this originate from the olfactory groove or this is part, the posterior part, this part, planum sphenoidal. Okay, tell him collectively, but the most important to pick up the disasters. And by the way, they may bring one case like this to make you consume the time in many side finding, and you lose some things like this, and he very يعني, he will be very easily to not pass you. Okay, so don't insinuate yourself in too much fine details away from the pathway of the case. Okay, my colleague.
Thank you, Doctor.
Also, in the case of brachial plexus, the candidate start, there are a big disaster in the right, and they, after, I think, 30 seconds, shift to the thyroid. Okay, you are right, but you can say this finding at the end. First, describe more and more. Try, do you know, my colleagues, when you are describing the diagnosis is developing in your mind. You are talking your mind, and your mind is, the idea is growing in your mind, and finally, after you describe, you may change your mind to the correct diagnosis. Okay? So concentrate in the main idea of the case. Thank you for all of you, my colleagues. Let's meet next week.
Thank you, Dr. Ram.